The invitation to attend Dad's guest lecture at Metropolitan Medical School should have been an honor, but sitting in the back of the auditorium, I knew it would become another public dismissal of my chronic pain condition. At 29, I was apparently the family member who exaggerated medical issues for attention, while Dad was the respected orthopedic surgeon educating the next generation of doctors. Today we'll discuss chronic pain presentations in young adults, Dad announced to the packed lecture hall. It's crucial to distinguish between legitimate medical conditions and attention-seeking behavior patterns. I shifted uncomfortably in my seat, my fibromyalgia flare-up making the auditorium chairs feel like torture devices. The condition had been diagnosed 8 months ago, but Dad had consistently refused to acknowledge fibromyalgia as a legitimate medical disorder. Many young patients, particularly women, present with vague pain complaints that lack objective medical findings, Dad continued, clicking to his first slide. These cases often involve psychological factors rather than genuine pathophysiology. The irony wasn't lost on me. While Dad was teaching medical students to dismiss chronic pain patients, I'd been quietly working as Director of Pain Management Research at the National Institute of Health. My published studies on fibromyalgia and chronic pain validation had influenced treatment protocols at major medical centers across the country. Dr. Martinez, a medical student, raised her hand. How do we differentiate between real pain and psychosomatic complaints? Dad smiled condescendingly. Excellent question. Real pain typically has identifiable causes: fractures, tissue damage, inflammatory markers. Psychosomatic pain lacks these objective findings and often correlates with family dysfunction or attention-seeking personality traits. I watched him describe my exact medical presentation to a room full of future doctors, teaching them to dismiss patients like me as psychological cases rather than legitimate medical conditions. For example, Dad continued, I have personal experience with a family member who claims to suffer from fibromyalgia, a controversial diagnosis that many physicians question. This individual presents with widespread pain complaints, fatigue, and sleep disturbances, but all diagnostic tests come back normal. Several students leaned forward, interested in the case study. My case study. The patient exhibits classic attention-seeking behaviors: frequent medical appointments, detailed pain journals, requests for specific medications, and emotional responses when physicians suggest psychological evaluation. What's your recommended approach for such cases? Another student asked. Firm boundaries, Dad replied confidently. Don't enable the behavior by validating unsubstantiated pain complaints. Suggest psychiatric evaluation and emphasize the importance of returning to normal activities regardless of subjective discomfort. I felt my face burning with humiliation as Dad essentially told a room of medical students that my chronic pain was imaginary attention-seeking behavior. The condition that left me unable to work some days, that required careful medication management and lifestyle modifications, was being presented as psychological dysfunction. The family dynamic is particularly important, Dad continued. Often these patients have learned that illness behaviors generate attention and sympathy from relatives. Breaking this cycle requires family members to stop reinforcing the sick role. So you recommend family involvement in treatment? A student inquired. Absolutely. Family members should be educated about not enabling pain behaviors. No special accommodations, no sympathy for unverified complaints, and definitely no financial support for unnecessary medical treatments. My phone buzzed with a text from Dr. Elena Rodriguez, CO of Metropolitan Medical Center. Allison, are you attending your father's lecture today? We need to discuss his teaching content regarding chronic pain patients. I typed back quietly, yes, I'm here. This is problematic. How would you handle a family member with these types of complaints? The student pressed. Dad's expression grew stern. I refuse to enable the behavior. When my own family member complains about pain, I explain that dwelling on subjective symptoms is counterproductive. I encourage return to normal activities and discourage medical appointments that reinforce illness identity. The lecture hall fell silent as Dad essentially admitted to medically neglecting a family member with chronic pain. Sometimes tough love is the most compassionate approach, he concluded. Enabling chronic pain behaviors ultimately harms the patient more than helping them. After the lecture, I lingered in the hallway as medical students filed past, discussing Dad's presentation. Their comments were troubling. Several had taken notes about dismissing fibromyalgia patients and avoiding validation of subjective pain complaints. Dr. Thompson really opened my eyes about chronic pain cases, one student said to her study partner. I never realized how much of it was psychological manipulation. Yeah, the family case study was really illustrative, her partner agreed. It's good to know we shouldn't feel guilty about questioning patients who can't prove their pain objectively. I followed them toward the faculty lounge, where Dad was holding an informal discussion session with interested students. Through the open doorway, I could hear him expanding on his lecture themes. The fibromyalgia epidemic is largely a social phenomenon, Dad was explaining to the gathered students. Young women in particular have learned that chronic pain diagnoses provide secondary benefits: disability accommodations, family attention, medication access. But what about patients who genuinely suffer? A student asked hesitantly. That's the key distinction, Dad replied. Genuine suffering has identifiable causes and responds to appropriate treatment. Fibromyalgia patients rarely show meaningful improvement because their symptoms aren't based in physical pathology. Dr. Sarah Kim, a rheumatology resident, looked uncomfortable. Dr. Thompson, recent research suggests fibromyalgia involves real neurological changes in pain processing. Dr. Kim, Dad interrupted dismissively, be careful not to confuse correlation with causation. Brain scans may show differences in chronic pain patients, but that doesn't prove the pain is legitimate. Depression and anxiety also show brain changes. So you think all fibromyalgia patients are essentially malingering? Another student asked. I think they're experiencing subjective discomfort that they've learned to catastrophize and medicalize, Dad clarified. The medical establishment has unfortunately validated this behavior by creating diagnostic criteria for subjective symptom clusters. I watched through the doorway as Dad essentially taught a room full of future doctors to dismiss chronic pain patients as psychological cases. The damage to patient care would be immeasurable. The family member I mentioned earlier is a perfect example, Dad continued. Despite normal test results and lack of objective findings, she continues pursuing medical validation for her pain complaints. She's seen multiple specialists, tried various medications, and even claims her condition affects her work performance. How do you handle family pressure to support her medical claims? A student inquired. I maintain professional objectivity, Dad said firmly. I don't provide false validation for unsubstantiated symptoms, even when it creates family tension. Enabling chronic pain behaviors ultimately prolongs suffering. Dr. Kim tried again. But Dr. Thompson, what if dismissing patients causes them to delay seeking care for legitimate conditions? That's a risk worth taking, Dad replied confidently. The greater harm comes from medicalizing normal life stresses and teaching patients to identify as chronically ill. My phone buzzed again. Dr. Rodriguez. Allison, can you meet me in my office after the session? We've received concerning feedback about today's lecture content. I stepped into the faculty lounge, drawing surprised looks from the students who recognized me from Dad's case study description. Dad, could I speak with you privately? He looked annoyed at the interruption. Actually, these students were asking about chronic pain management approaches. Perhaps you could share your patient perspective. The suggestion was clearly meant to embarrass me, putting me in the position of defending my condition to a room full of medical students who'd just been taught to view fibromyalgia as attention-seeking behavior. I think there might be some misconceptions about chronic pain research, I said carefully. Misconceptions. Dad's voice carried a warning tone. Recent studies from the National Institute of Health have identified significant neurological markers in fibromyalgia patients. The research shows measurable differences in pain processing pathways. And where exactly did you encounter this research? Dad asked condescendingly. I've read several peer-reviewed studies on the subject. Dad smiled patronizingly at the students. This is exactly what I mean about chronic pain patients becoming overly invested in medical literature that validates their experience. Actually, I continued, I've contributed to some of that research myself. Contributed how? Dad's tone suggested he thought I meant participating as a patient subject. I'm Dr. Allison Thompson, Director of Pain Management Research at the National Institute of Health. I've published extensively on fibromyalgia pathophysiology. The room went completely silent. The faculty lounge fell dead silent as medical students processed what I'd just revealed. Dad's face cycled through confusion, disbelief, and dawning horror as he realized the implications of what he'd been teaching. "You're Dr. Allison Thompson?" Dr. Kim's voice was barely a whisper. "You wrote the landmark study on central sensitization in fibromyalgia patients?" "I did. Along with the NIH protocols for chronic pain validation that most major medical centers now follow." One student pulled out his phone, frantically searching. "Dr. Thompson's research has been cited over 3,000 times. She's considered the leading authority on fibromyalgia pathophysiology." Dad's face had gone pale. "Allison, you never mentioned that I'm a respected pain researcher while you've been telling medical students that my condition is attention-seeking behavior?" I kept my voice level and professional. "That seemed like information you might have found relevant." Dr. Rodriguez appeared in the doorway, clearly having arrived for our scheduled meeting. "Dr. Thompson, I see you've met our guest lecturer. Dad, I'd like you to meet Dr. Elena Rodriguez, CEO of Metropolitan Medical Center. She's been implementing our NIH chronic pain protocols hospital-wide." Dr. Rodriguez stepped forward with unmistakable authority. "Dr. Thompson, the elder Dr. Thompson, we need to discuss some concerning aspects of today's lecture content." "Concerning?" Dad's voice was strained. "You've essentially taught medical students to dismiss chronic pain patients as malingerers, contradicted evidence-based research, and used a family member's medical condition as a case study without consent." The medical students were shifting uncomfortably, realizing they'd witnessed something problematic. "Furthermore," Dr. Rodriguez continued, "you've described providing substandard medical care to a family member with a legitimate chronic condition. That raises serious ethical concerns about your clinical judgment." "I was trying to provide educational context." "Dr. Thompson," Dr. Rodriguez's tone was ice-cold, "you used your daughter's medical condition to teach students that fibromyalgia patients are attention-seeking malingerers. Your daughter, who happens to be the nation's leading researcher on the exact condition you were dismissing." Dr. Kim looked stunned. "Wait, Dr. Allison Thompson is your daughter? The Dr. Thompson whose research protocols we study in our chronic pain rotations." "The same Dr. Thompson," Dr. Rodriguez confirmed, "whose NIH funding supports this hospital's pain management research programs." Dad was now visibly sweating. "I didn't realize Allison had achieved such recognition in her field." "You didn't realize because you never asked about my work," I said quietly. "You were too busy explaining why my medical condition was imaginary." Dr. Rodriguez addressed the students. "I want to be clear. Everything Dr. Thompson presented about chronic pain today contradicts current evidence-based medicine. Fibromyalgia is a legitimate neurological condition with measurable pathophysiology." "Dr. Rodriguez," one brave student asked, "should we disregard today's lecture content?" "Completely. In fact, Dr. Allison Thompson's research forms the foundation of our current chronic pain treatment protocols. I suggest you review her published studies rather than today's outdated perspectives." Dad looked around the room desperately. "Elena, surely we can discuss this privately." "Dr. Thompson, your guest lecturing privileges at this institution have been terminated immediately. Additionally, we'll be reporting this incident to the Medical Ethics Board for review." "On what grounds?" "Professional misconduct, patient confidentiality violations, and teaching content that contradicts evidence-based medical practice." The students began filing out quietly, clearly uncomfortable with witnessing a faculty member's public downfall. By Wednesday morning, word had spread throughout the medical community about Dad's disastrous lecture. Dr. Rodriguez had submitted a formal complaint to the state medical board detailing how a practicing orthopedic surgeon had publicly dismissed evidence-based chronic pain research while admitting to medically neglecting a family member. "Allison, we need to talk," Dad called Wednesday evening, his voice shaken. "I assume you heard about the medical board investigation. They're reviewing my medical license. My teaching privileges have been suspended at 3 hospitals." His voice cracked. "How was I supposed to know you were some kind of chronic pain expert? You could have asked about my work instead of assuming I was unemployed because of my condition. I thought you were just doing consulting or something minor." "I've been director of pain management research at NIH for 4 years, Dad." I've published 67 peer-reviewed studies and oversee a $40 million research budget. The silence stretched between us. The medical board wants documentation of how my family medical opinions might have affected your treatment, he said quietly. I'll provide them with a complete record of how my own father refused to acknowledge my chronic pain condition while teaching medical students to dismiss fibromyalgia patients as malingerers. Allison, this could destroy my career. You destroyed your own career when you used my medical condition to teach students that chronic pain patients are attention-seeking liars. Can you help me appeal this? Explain that I was just misguided. That I can't fix this. Your lecture contradicted 4 years of my research and violated patient confidentiality laws. The Medical Ethics Board takes these violations seriously. Friday afternoon, Dad's orthopedic practice issued a statement announcing his voluntary retirement pending ethics review. 3 medical schools canceled his remaining guest lectures. Dr. Rodriguez later implemented mandatory chronic pain education for all faculty, using my NIH protocols as the curriculum foundation. 6 months later, I received the National Medical Research Excellence Award for advancing chronic pain understanding. Dad attended the ceremony sitting quietly in the back row. During my acceptance speech, I emphasized the importance of believing patients and validating their experiences, lessons some medical professionals still needed to learn.